We see the human and we personalize our support according to what that human is going through at any particular time. It does not just live as a physical entity. I often talk to patients that actually your body doesn't really feel pain, your brain does. And that's what Synthesis Clinic is really all about. It's about providing care that I wish I could have had at the time when I was diagnosed.
Hello, everyone. Nice to meet you again to a new edition of Beyond the Cancer Diagnosis Interview Series. Today is my pleasure to have a wonderful guest, Dr. Nina Shavel. She's a medical doctor, scientist, and educator. Nina, thank you for accepting my invitation. Thank you for being with us today.
It's lovely to be here, Adrian. Thank you for inviting me.
As for the topic, it is more or less your main field of expertise, integrative oncology, but this time from a psychosocial dimension. As I'm always doing on my interview series, I will try to see the psychosocial, the emotional dimension of cancer on humans, but from different point of view, from different angles. Integrative oncology nowadays, it is a subject that it's very broadly, on my opinion, and not only. And to start our interview, I will kindly ask you to give let's say, more or less of definition or explanation of what integrative oncology really is and how this approach influence patients' emotions, psychosocial outcomes, and so on.
Sure. So integrative oncology is a patient-centered, evidence-informed field of healthcare where we marry up the best of the standard of care therapies with mind-body approaches, lifestyle modifications, natural products. And the aim is really to help improve patients' resilience, optimize quality of life, manage side effects better, and of course, support better clinical outcomes. So I think of integrative oncology as very much the best of all worlds. You want to be able to achieve the best standard care according to guidelines, according to the latest precision medicine, maybe. But we also want to make sure that we don't forget the whole human aspect. And that's where the psychosocial aspect really comes in. Because when I talk to patients in my integrative oncology consultations, we very much cover everything from their nutrition to how they move, what they enjoy doing, what do they do in terms of joy, what brings them joy, what might be the stresses in their lives, what might the ecosystem look like for them at the moment, both in terms of internal ecosystem, but also externally, family, friends, carers. What does their support network broader look like? How can we support them in having good sleep, good psycho-emotional well-being? So all of that to me is a really core part of integrative oncology.
You more or less mention the majority aspects of things that every oncological patient deal with.
Yeah,
nutrition,
absolutely.
Emotions, counseling, and internal, external. So we can say that integrative oncology is kind of, let's say, more or less a therapy on many sessions.
Yeah, I think from my perspective, I usually work in a multidisciplinary team. So, as a physician, my role is to head up a multidisciplinary team and to join up all the different bits of care for the patient. So I am very much the leader of the case. So we will talk about everything, like I said, very broadly, but I'll also direct patients to specific interventions. So, for example, if we think they might benefit from clinical psychology, we will direct them there. If they maybe respond more to yoga therapy or want to try art therapy or music therapy, again, we have resources to refer them to that. It may be that they want to do something that is maybe actually nothing to do with talking at all. They actually just want to do movement-based therapies. So we're looking at dance workshops or dance therapies as well. So it's really very much about finding the right fit for the patient's needs at that time, but also dynamically changing that as they go through their journey. The point isn't that I issue an integrative oncology plan and then it's done and I'm dusted and everything's fine. But that actually over a series of meetings, we will coordinate that plan, we'll receive feedback on what's worked or hasn't worked for the patient, new challenges on their treatment journey, what's different for them now, during surgery, for example, preparation for that, maybe post-operatively, chemo, immunotherapy, radiotherapy, survivorship, or entering the phase of living well with advanced cancer and going through different lines of treatment, palliative care. All of those are covered in a different way dynamically through the patient pathway. And as I said, I have a wonderful team to support me. So I don't do everybody's nutrition. I certainly can guide them. Thankfully, I'm a registered nutritionist as well. But I also have a team who very much create a care plan and deliver that for the patient. And as usual in oncology, we also have MDT meetings. So in our multidisciplinary team meetings, we would discuss patient care, make sure everybody's up to date with the updates, both from the treatment perspective and any important events for somebody. Has somebody lost their favorite pet at the same time as they've been given really bad news from a scan? That's something we want to manage proactively as a team.
And I believe in this sense, or starting from these issues, you founded Synthesis Clinic, which is your, let's say, soul project. And I'm very eager to find out the story behind this initiative, its missions, visions, values, and what you provide for the oncological patients.
Well, it all started with my journey, actually. So I was diagnosed with breast cancer with a HER2 positive grade 3 breast cancer at age of 33. I was parenting a 3.5-year-old at the time. So you can imagine, as a doctor, you find a lump, you tell yourself, oh, don't be silly, it's fibrocystic disease. And so it completely came out of the blue for me when I was diagnosed. And I think as a general medicine doctor, so I used to practice general internal medicine, I always thought, surely, people with cancer will get all sorts of advice on how to support them through the cancer treatments. And I was treated fantastically from the conventional care perspective, received amazing care, but very few people, or pretty much nobody in the first few months, ever asked me how I was coping with the diagnosis. Was I sleeping? What was it like trying to parent a child through cancer treatment? Do I have enough support at home? So I think it was really interesting dynamic for me to realize just how little support we give patients as humans, not just as their diagnoses. So when I finished my own cancer treatment and my own sort of double surgery, chemotherapy and targeted therapies, I've decided to come out of the NHS where I worked at the time and found my own clinic. And that's what Synthesis Clinic is really all about. It's about providing care that I wish I could have had at the time when I was diagnosed. So it's about working together as a multidisciplinary team, because I feel that that's a fantastic way of bringing the conventional care aspects, the best of conventional care, is working as a team, but providing people with broader range of modalities and support. So we would work very closely with the patient's oncologist to provide specialist input in integrative oncology, nutrition, physiotherapy and cancer exercise support, psychoemotional well-being support, different types of therapies in terms of yoga and art therapy. We would look at all sorts of different angles in terms of opportunities to be able to optimize the patient. And we do it in a personalized way as well, which is really important to me. The fact that we sometimes I feel as patients in the system, that we're just cancers walking around on legs, right? Sometimes I feel like that's how the system treats us. But we are human with our own hopes, dreams, ideals, problems. And to me, that's what the clinic aims to do. We see the human and we personalize our support according to what that human is going through at any particular time. So we will look at the biochemistry, we will look at everything to do with conventional treatment, but we go beyond that to try and really support the patient and their network when we get the chance to as well.
You mentioned about personalized integrative care. And when I was looking on your website, I saw the integrative pain service. And we all know that cancer-related pain, cancer-related fatigue are two, let's say, most common side effects for every oncological patient. Managing pain during cancer is one of my field of expertise, to put it this way. And I'm very interested if you can share more details about this personalized pain service for oncological patients.
Sure. So I think from the medical side, to me, the first thing is to actually diagnose the pain correctly, because it's an amazing amount of time we just give patients opiates, right, without actually diagnosing whether the pain they have can actually be helped by opiates or whether there should be other interventions. So a lot of the time it's about, first of all, doing a really good medical job of diagnosing the pain and where it's come from, and what the likely cause and prognosis of that pain might be. So, for example, if we're dealing with peripheral neuropathy that's related to maybe platinum or taxane treatment, we know that actually if somebody experiences that quite early on in their course, it's a flag to me to speak to the oncology team to say they've already started experiencing neuropathy quite early on. Please do watch that in case you want to make a dose adjustment. We would want to put in things proactively for a specific kind of pain. So another example would be aromatase inhibitor associated arthralgia. So all of that joint pain that women can go through on aromatase inhibitors. The targeted intervention for that would be acupuncture, for example, and movement. And we've got wonderful SAO ASCO joint guidelines on pain and integrative modalities that can be helpful for different kinds of pain. So we need to be looking at specifically what kind of pain is it? Is it periprocedural pain? Is it neuropathy? Is it general musculoskeletal pain? Are we talking about pain in the palliative care setting? Is massage more appropriate at that point because it's gentle? So somebody who's trained in oncology massage might be able to deliver that. And of course, pain does not just live as a physical entity. I often talk to patients that actually your body doesn't really feel pain, your brain does. So we're thinking about how that's being processed and what other supporting strategies we can put in, including psychological support, including what else can help us cope as a general coping strategy. So we will look at coping strategies for patients. That might be different for different patients and different pains. So that assessment really for us is done within the integrative oncology or integrative pain service. So one of the doctors will do the initial assessment, and then they will make a course of treatment recommendations, which might include things like acupuncture or massage, or it might involve some of the supplementation that might have a specific role in targeting certain symptoms. But it will very much depend on what pain, what the current management is, and not forgetting that we have access to a really broad range of modalities in integrative oncology.
You mentioned the first and foremost, yes, to diagnose pain correctly. And here I would like to ask you because it looks like a debate, between researchers, scientific person and so on, between perceptive pain and sensorial pain. And there is a percentage or which kind of pain feel the patient in the majority of cases, because me also as a therapist, to put it this way, I always heard patients complain about the pain, but they are complaining about something as a perception of a pain, not a sensorial one. And there is a percentage, or which of these two terms come first in general?
I think you have to take in the whole picture. I think there's a whole nociplastic and central sensitization we have to think about as well, right, for people, because I see that a lot of the time in pain scores. What I see objectively and what the patient perceives might be quite different. And I think we have to see the whole picture, because if your objective and subjective are vastly different, we have to consider what kind of overlay there is and why that overlay is there. Is it central sensitization? Is it something else? Is the person is so overwhelmed from multiple different directions that their pain perception is therefore screaming at them from that particular point? But I like to think that we need to evaluate both. So I will do an objective evaluation as well as a subjective one. And we have to look at both, because otherwise we are leaving part of the picture out.
And the patient will go without an answer. And always patients want something concrete, If you say something, it's only a perception, they don't agree, because it has to be something there, because he feel it. And I also know that you found it also an application on your app. And this is the first application or apps, or how it's called nowadays, for cancer patients. Again, this is a subject very disputed today in, let's say, digital world, in e-health and so on. And there are different opinions. Why a cancer patient should download and use your app, for example?
So OnQ app aims to position itself very much within integrative oncology. We don't try to be all things to all people, but what we know is that evidence-informed integrative oncology sources are really sparse out there. People will Google things as they would because they want to find good information, and they will come across all sorts of rubbish. So what we want to do with the app is that we know there's a significant gaps around information, anything from nutrition and accessible recipes to being able to access some basic exercise oncology information. We know there's a significant gap in provision, and we've actually done a survey that we presented at 2 international congresses on that before we designed the OnKio app, because the app design was very much informed by talking to patients with cancer and saying, where do you find the oncology teams are not giving you enough information? Where do you feel the gaps for you really are? And so when we designed the app, we really aimed for it to be a supplemental resource to the normal oncology standard of care. And it doesn't aim to replace every single app, but it aims to be an authoritative provider within the integrative oncology field. So within it, there are some programs. So there are guided programs that have been written by experts in their field. So for example, a cancer access specialist does prehab and rehab. There's a mindfulness program that's been led by somebody who is not only a mindfulness teacher, but also has lived experience of cancer. There is a yoga for cancer, 2 programs actually by a really hugely experienced teacher called Vicky Fox. There's a Qigong program. So we're trying to make sure that if you cannot access something like this locally, you at least have access to it digitally. Of course, it'd be wonderful if I could send you to a yoga for cancer class, but maybe you live in rural Scotland and there's absolutely zero chance of you ever accessing a yoga for cancer class because your nearest person is 2 hours away. We're actually preparing a self-acupressure program at the moment. So again, if people can't access acupuncture, could they do some simple self-acupressure at home to try and help manage their symptoms? And then on the other side of the app as well, there's a library of resources. So anything from recipes that are free to use to articles about different integrative oncology therapies, so people can understand what they are, how they can help, and also where to find a reputable practitioner. So that's what we really aimed to build. We aimed to build an integrative oncology resource that is evidence-informed, that's well-referenced, that's written by experts, and that can cut through some of that misinformation that we find on the internet or on social media.
You mentioned 2 very important things for our audience and for patients with this app. First is information, reliable information, because I have previous interviews about information in cancer care, especially in IAS. And I always said that there is a difference between misinformation and disinformation, because disinformation is something that you put it on, let's say, social media with the intention, with a bad intention, and misinformation is what you think it's correctly, but not for everyone. So this is very important, information from reliable sources. But the other thing for me, it's even more important. You mentioned rehabilitation, and I have to admit or to notice that you're my first guest that bring into attention this notion of rehabilitations of cancer patients. In Romania and in Eastern Europe, we are dealing with these issues of former, let's say, in this way, cancer patients or cancer patients free, who wants to return to work, but due to, I don't know, lack of bureaucracy, of administrative things, can't work anymore, or can't work on the place that they used to work. And this thing of rehabilitation, of rehab, it is very important. And it will become more and more important on the future, because otherwise we will enter in this field of stigmatizations, and we don't want to go there. And this is very interesting. Do you have some concrete issues about rehab, or just general information how they should do or what they could do?
Well, I think to me, the studies really show that multimodal rehabilitation programs work best. And that's, to me, multimodal rehab means making sure that we provide advice on nutrition that is consistent with the latest evidence, that isn't just going to be a government eat well plate, because actually that's not necessarily what is appropriate for people. The second part is movement, and that's movement that is tailored to the person, meets them where they're at, and also is something that they will enjoy doing and can do consistently. Because if you can recommend running to somebody and they hate running, guess what? They're never going to do it. And actually, they're not going to help improve their fatigue and function. Sometimes people say to me, oh my goodness, you're going to make me do yoga. I hate yoga. I'm like, don't do yoga. Do qigong, go swimming, do cycling. I don't know, anything that you enjoy. Some of my patients love dancing. So go do dancing. That is absolutely part of the rehabilitation package. The other bit, of course, is really important, is the psycho-emotional well-being, is actually getting quite a lot of the time we find, and hopefully you find the same, Adrian, is that people go into fight or flight during active treatment, and they kind of just get through it, and they almost don't have time to think about what's just happened properly. And they just put one foot in front of the other. And then treatment stops, active treatment stops, and they get discharged to follow-up. And that's when most of my patients faceplant. Because they actually then, the enormity of what just happened has hit them. And all of that support and regular contact with your oncology nurse and your oncologist and maybe other support teams have been withdrawn. You're going to see them in 6 months' time or maybe a year's time. So a lot of the time, this is a crisis point for patients they haven't been warned about. So I talk to all of my patients during active treatment who have primary cancer to say, I know we are approaching the last couple of months of your treatment. Please don't be surprised if you find that actually survivorship, beginning of survivorship phase, is actually tougher than what you think, because nobody warns them about it. And then they think they're the weird ones, the strange people who actually found it tougher than the last bits of chemotherapy. So we preempt it, we warn patients about it, and we put in extra support around the transition point for them. And we also run things like group programs. So I think group programs of finding community and trying to transition yourself mentally from just surviving this journey to thriving. What does life look like actually as a thriver? What are my new priorities? What do I want out of life now? Because it will be something different than what I wanted pre-cancer. So trying to do those shifts together as a community is also really helpful. And we find that using those group courses and group interventions, an effective intervention alongside any additional one-to-one work that somebody might do.
Since we are approaching the end of our interview, the time is passing so quickly. I would very much like to discuss a little bit about Society for Integrative Oncology, where you are a co-chair on the global committee. Could you name the main directions that this society needs to take in this world out of balance to improve the lives of people affected by cancer?
Well, I think SIO has done amazing work already. I think one of the key contributions that we really need to celebrate is the joint SIO-ASCO guidelines, because these are the first guidelines that have been done together with conventional oncology and integrative oncology that have involved experts from across the world for specific problems. So pain, anxiety and depression, where I was one of the co-authors, and more recently fatigue. So continuing to work on those guidelines, I think, is absolutely crucial, because that means that we can help standardize clinical practice a little bit. Guidelines are not prisons. You are still allowed to do your own clinical thinking. But being able to really raise the standard of integrative oncology practice across the world, we do need guidelines. So I think that's a key one. For me, globally, as a chair of global committee, it's really important that we look at global practices, but we also act locally. So we want to create global collaborations, but we want to institute and support culturally sensitive local interventions. And we want to make sure that whatever we're doing is right for both the patients and the clinicians. Somebody working in Brazil versus somebody in Africa versus somebody in China, somebody in Romania, like you, Adrian, somebody in the UK or in the US, top teaching hospital. We all have very different environments. We operate within different oncological environments, social environments, cultural environments. So we need to make sure, I think, that whatever we do, we also are able to adapt and support people in making sure that it isn't a global directive and then everybody just carries that out, is that we're able to adapt and make it our own and make it work for our patients in our context. And for me, research, of course, I was going to say research. Everybody says research, but research is so crucial. And integrative oncology receives so little funding compared to conventional oncology research. I often think about just how much money goes into making wonderful therapies, but we have to cope with the side effects of those therapies. And not nearly as much research money goes into helping optimize side effects and supporting the quality of life of patients. So I would like more investment into research, into care models, and how to support best quality of life for people for as long as possible. Because while it's not maybe the most sexy research topic, it's the one that matters for our patients at the coal face. They want to not only survive, but be able to do so with the right quality of life and good symptom control.
As for the last question, I was prepared one. A statement that you agree or not, but you mentioned something very interesting. So I will change the statement, and if you can tell me if you are agree or not. You mentioned about research, of course. Education is one of your fields of expertise, which is hand in hand with research, more or less. And nowadays, there was on LinkedIn discussions about starting from this point. We need more research. Everyone said we need more research, but nobody's starting doing something. Are you agree with this, that we have to start doing and going hand in hand with research and not waiting for more research than doing something? Because this was the discussions when we should try to implement something, we can't because we need more research. It was always this excuse sometimes that we need more research. Are you agree or not that first we have to start doing with what we have now and going hand in hand with the research part?
I think we have to do both almost. I think the implementation-based research is very important. So we clinically audit our practice all the time at Synthesis Clinic. We built in patient-reported outcome measures so that we know what's working or not, both for patient groups, but also for individual patients. And we use other things like biomarkers as well to assess how effective we're being. So I think that kind of implementation-based research is really important. And we also know what works in our clinical practices, right? Therefore, doing some evaluations as we go along is also important. However, there's also a place for a good big trial to really answer some big questions about what's effective and what's not effective in integrative oncology. So I think there's a place for both. And I think that we need to work with both. And real world data is very important to me, because I think ultimately we also need to recognize that in lovely, neat, randomized control trials, we exclude vast majority of the patients who are our usual day-to-day work, Adrian, right? The people with kidney disease and with liver disease and with diabetes and with all the problems and multiple comorbidities. We don't study those patients in randomized control trials quite often, but yet that's patients that we work with. So we actually have no evidence-based medicine in those patients because the trials are not done in those patients. So real world data can help us really answer in the context of what we are doing right now with all of our complicated patients, what is working for them and for the subgroups within those patients and what might not be working. And then we can unpick some specific questions in terms of effectiveness in trials. I think it's really different. We need to think about efficacy versus effectiveness. And both, I think, are needed to be able to push the research field forward.
Nina, thank you very much for the explanations, for the insight, for what you share with us today from your work, which is impressive, and for what you mentioned, that global is local and local is global at the end. Thank you very much. Good luck further, and hope to see you next time at our interview series.
Thank you very much, Adrian. It's been a pleasure.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.